You're listening to the Physio Matters podcast in association with exerciseprescriber.com, and this is session 65. Welcome back to the Physio Matters podcast. I'm still Jack Chew, and thanks so much for tuning in once again. Brilliant feedback again for episode 64. Thanks so much to Maddie and Rory for that deep dive into motivational interviewing. Because of the reaction to it, we're also going to get them at the conference for the Big R's conference in October 18th and 19th, delivering a workshop, just trying to tease out some of the details into practical application of motivational interviewing. So looking forward to working with them on getting that together. So do join us if you're interested. reform.physio/conference, or visit buytickets.at/reformingmsk. Those tickets are selling really well, and we're just about to launch the program. So if you are interested, then please do snap them up, because this soon will be gone. We've got lots of exciting stuff coming on the show in the coming weeks. You might have noticed across social media that we're launching Patient Matters and Health Matters imminently. Thank you so much to those that crowdfunded those shows. We've decided that we're going to put those live as we record them onto Facebook Live, and then the audio from those will then be released in between Physio Matters podcast episodes. And so if you're wanting those as they come out, then you can actually access them live and on video, audio on Facebook from then. Or if you want to tune in as you normally do through your podcast apps, then there will be probably only a week or so's delay on those, depending on when we record them in the week. So yeah, lots to look forward to, and including this episode, which is with Chris Mercer on Cauda Equina. Huge hot topic, and we talk a little bit about why that is at the moment, and we really do go through it in thorough detail. Incredibly important topic, as all of you will be aware, but also one that comes with lots of different contentions and nuance. Can't think of anyone better than Chris to discuss these issues with. As I mentioned, or garble a little bit at the start of his intro, he's a real friend of the show in many ways. We've got a lot to thank him for involving us in IFOMP 2016 and some of the precursor materials and promotion for some of the keynotes for that event, which was brilliant. That was up in Glasgow. And he's someone that's we've had an awful lot of respect for, as you, I'm sure, will do too, for bringing nuance and sensible conversation to a debate from his involvement in MSK over the years. So definitely one to follow and one to look out for, and one to pay attention to any project that he's involved in. So it's great to get him on the show and to involve him again in the conference as well in October. He'll be there, and we'll be taking questions and trying to offer some detail into Cauda Equina, and no doubt the conversation will have further moved forward when we get to that point. So, as per usual, thanks so much to exerciseprescriber.com, our sponsors who kindly support these episodes and keep us on the airwaves alongside our brilliant crowdfunders for the other shows. As you can imagine, we've tested many different software and different companies over the years that have sent us links to check out their work for exercise prescription, but they really are the best of the bunch, and so you should check them out too if you haven't already at exerciseprescriber.com. And that reminds me, if you wish to support the Physio Matters podcast and its various assorted and ever-growing set of projects, then do check out choosehealth.co.uk/support, which is our new online donation platform where you can give one-off or subscription amounts of just a few quid that can keep us ticking over and doing what we do. Thank you so much as ever for listening. I'll see you at the end of this episode. For now, I bring you Chris Mercer and Cauda Equina Syndrome. Delighted to be here today with Chris Mercer. Long time, I could argue, friend of the show, because in 2014 he gave us what I consider to be a big break involving us in some of the IFOMP pre-releases for the conference for 2016, and has been someone whose work I've admired for a long time, especially in and around this area of serious pathology, and namely Cauda Equina Syndrome. So it's absolutely brilliant to have Chris Mercer come on Physio Matters to discuss what is an incredibly hot topic at the moment. And we'll hopefully touch on why that might be, and some of the oohs and ahs and changes over the years. But welcome, Chris. Would you like to introduce yourself for the listeners?
Yeah, thanks, Jack. I'm Chris Mercer. I'm a physio consultant with a particular interest in musculoskeletal and a particular interest, I guess, in serious spinal pathology. So my interest in serious pathology came around through an unfortunate incident with a patient. And it was all a bit of a car crash when I was a junior musculoskeletal physio. And this chap came in with what I thought was a C8 T1 nerve root compression. It's a chap called George when I was working at St George's, and George was a bit unkempt. He was not the sharpest tool in the box, and he came in and he swore blind to me that he had cancer. And I said, no, you don't, George, you've got a C8 T1 nerve root irritation and I'll get it better. So I treated his neck and George got better, except for a tiny bit of numbness in his little finger. So I said, all right, George, we'll go off for 3 weeks. Come back and see me in 3 weeks. You'll be fine. It'll go in 3 weeks. So off he went. 2 weeks later, the inpatient orthopaedic lead came downstairs and said, you know a bloke called George? I said, yeah. He said, well, he's up on the ward. He's got a message for you. Okay. So I went up onto the ward, and George was propped up in his bed down the far end of the ward, and he just turned around and he shouted down the ward, I effing told you so. And George had a tumour from C6 to T6. And wow. That kind of shook me up a bit because George died 2 weeks later in hospital, having had massive surgery. So it wasn't a great way for George to end his life. And for me, it kind of pulled me up short in terms of what I'd missed, really. Right. And kind of, I suppose, introduced me in a fairly harsh way to the reality of what we were seeing in musculoskeletal physio. So then I kind of read around a bit and got hold of Greg Greaves' Masqueraders chapter and thought, oh, blimey, there's quite a lot out here that I don't know. And kind of went from there, really. And then the other, I suppose, relevant patient for this podcast is my first negligence case, which happened about a year after I came into my consultant post. And it was a 31-year-old lady who ended up having a Cauda Equina compression and ended up being incontinent, having to manually evacuate her bowels and having saddle anaesthesia and loss of sexual function and being left like that. So those kind of two patients, I think, probably that really focused my interest on red flag pathology and Cauda Equina.
Yeah,
and
certainly.
Through that,
sorry,
sorry, go on.
No, just certainly landmark points in your career, and I know you've spoken before about wanting clinicians to not have to go through those moments themselves and to try to learn from others, because those are things that, of course, were naturally going to wake you up. But we're hoping that the learn by experience isn't going to be first person for every clinician. Otherwise, there's an awful lot of people that end up encountering the worst of it.
Yeah, I think so. And I mean, I've obviously reflected on those two patients quite extensively, and I don't think, in reality, whether I certainly wouldn't have done anything different with the second patient, the lady with the Cauda Equina. But with George, I think I would have listened more and should have listened more, and I think that's probably the one thing that would carry through with most of these cases of serious pathology and Cauda Equina is that you really need to listen, and your communication needs to be at a very high level. You need to be very clear to the patient what you're asking, and you need to listen very carefully to what they're saying. So those are the things that I took from both those patients. I couldn't have affected the outcome in either of the patients, but might have managed it better, I think. I think we're all going to come across these patients, but it's doing the best we can by them. I think that's important.
Yeah, wow. And so in your career journey then, has there been, because it's not just on red flags you've been involved with the MACP for many years and other things. Have you always been musculoskeletal? And did that ever feel like it, and because I suppose I'm projecting a little bit here, does being interested and specialised in musculoskeletal, has that dragged you almost too far away sometimes from medical stuff? And therefore these cases that you're describing Has that dragged you back? I know I've personally had those sorts of tug of wars in my career.
Yeah, I think being involved in MSK and the spinal work that I'm involved in has moved me more towards the broader medical model. And I think a lot of the time I reflect back to, I did 3 years on care of the elderly when I first qualified, a combination of care of the elderly and community. And I think having that broad base and that broad foundation actually introduced me to a lot of serious pathology. So it wasn't that much of a change, but I think increasingly as I've got more experienced or older, then I think I'm moving more towards having a broader medical knowledge. And I think what you end up doing is finding more serious pathology.
Yeah.
And I think it's not that the patients are changing, it's that you ask more questions and you listen better. When I first started at Worthing Hospital, where I am now, after a year, the consultant radiologist said, I don't know what's happening to the population here. Since you've been here, we've had far more serious pathology. There must be something in the air. And that was like, well, probably not. I don't think the population of Worthing's changed very much. It's just, that the physio team are asking more questions and probing a bit more. So it was quite an interesting way of looking at it, I guess.
Do you think that there is, to some degree, I mean, because I certainly see nothing there that I disagree with. However, I do wonder, are physiotherapists, though, a little more exposed to a population that is ailing and aging to some extent, so multiple comorbidities, self-referral, first contact practice, that sort of stuff? Does that mean that we've got more exposure to those sorts of things, perhaps, than we might have done in decades gone by?
I think there is, in terms of the increased access, and I think there are increased risks, I guess, with first contact practitioners. I think a lot of the competency framework around the first contact practitioners has rightly focused on some of the serious pathologies, and I'd only hope that people in those posts are well supported and have the right governance arrangements. Because I think they will come across more serious pathology. Because I think GPs do a bloody good job on the whole in screening out a lot of the serious pathology before it gets to us. And so I don't think we are completely exposed to everything. But also we've got an ageing population, so older people get more serious pathologies, although not generally Cauda Equina. 70% of Cauda Equina is in under 50s. Yeah. So it's predominantly so the ageing population shouldn't particularly affect those numbers.
Yeah, I want to get into the numbers and perhaps other details of what that demographic would be in a sec, but I want to make sure we don't miss a chapter of what is Cauda Equina, and so I'm sure that's something that you're used to having to have on your opening slides. So could you just give us a clue as to what it is, and then we'll go into incidents.
Yeah, well, it sounds like an easy question, Jack, and I think it's the right question. What is it? But definitions for Cauda Equina are pretty hard to come by. Fraser did a study with Lisa Roberts a few years back and trawled through the literature trying to find unanimous descriptions of what Cauda Equina is, and couldn't find any. So what we think is easy probably isn't as easy as it might be, but there are a few kind of helpful definitions, I think. So things that we should be concerned about is anyone with back pain plus or minus urinary symptoms, bowel symptoms, sexual dysfunction, and loss of saddle sensation. And that would be plus or minus leg pain. So those would be the easy things to look for, I guess. In its broadest sense, there are some definitions. People like the British Association of Spinal Surgeons have a broad definition that says anyone presenting with acute back pain or leg pain, even with a suggestion of a disturbance of their bladder or bowel function, plus or minus saddle sensory disturbance, should be suspected of having or developing a Cauda Equina syndrome. So that doesn't include sexual dysfunction, but it's a nice broad description, and that's been taken on by UK SSB, which is the Spinal Societies Board. So it's kind of a fairly good level of buy-in to that as a description. And the National Low Back Pain Pathway clinical network, has endorsed that as well, adding in the sexual dysfunction.
And with regards to the Cauda Equina, as a word and things, I mean, we don't need to get too far into the Latin of the term and things like that. But I'm just meaning in terms of anatomy and things like that. What is it referring to, and how much variance is there in that anatomy between people?
Well, in terms of variance of anatomy, there will be some, but generally what we're talking about for the Cauda Equina is the sacral roots, particularly the sacral roots being affected, causing the bladder and bowel sexual dysfunction. So, but obviously the Cauda Equina is down from the conus down to the sacral roots. So anywhere down through there that you're getting compression, but particularly we're interested in S1 to 5 roots.
And sometimes people get a little sucked into when it's referred to where the cord splits, etc. on an MR, that sometimes people think that there's some relevance when, if the symptoms are there that you're describing, then of course people need to not necessarily get sucked into thinking that the variance is going to then mean it's less serious or what have you.
No, I mean, you can get very similar symptoms from cord compression or conus compression, slightly mixed picture. Slightly different picture to Cauda Equina, but similar presentation. So, but the questions that we'd ask around Cauda Equina would still be relevant and still stand. So, I think it would, as would the examination, the physical examination.
Okay. In MSK for physiotherapists and in MSK generally, obviously osteopaths and chiropractors, anyone encountering anything early on or during a process or episode of care, there's very few urgent medical emergencies in a sense that will be considered under a condition. Obviously we can see various emergencies, but particularly for this it's considered the thing that needs very expedient care. So what is there anything else around that makes it unique, and therefore do you feel it deservedly is treated very seriously and we have these conversations as a matter of priority?
I think it's urgent because the time frame, excuse me, and the window that we can act and make a difference to people's symptoms is so small. So this, along with metastatic spinal cord compression, are probably the two biggest emergency conditions we'd come across, and for the same reason. If we delay, then people are going to end up either off their feet in the case of metastatic cord compression, or suffering incontinence or sexual dysfunction permanently in the case of Cauda Equina. So it's the time to act that's the key. We have a very small window where we can change people's outcome. Yeah,
absolutely, and I think we'll probably come onto that in a little while with regards to action and time of action and things. With regards to incidents, then, what are the? I mean, unfortunately, I think it's something that I've experienced in my career, various different, and I think I had that naivety as well when I came into it, is to thinking that this was a once in your career incident if you're unfortunate. And that has just not played out for me, in part because I was very involved in self-referred services even as a junior, and so incidents certainly felt far higher than that for me. What are the percentages as we understand them as it stands?
I mean, I think the honest answer is we probably don't actually know.
Right.
We know the number of operations that are done, and we know that around 2 to 6% of operations for discectomies are for Cauda Equina compression. But in terms of prevalence, we know probably between 1 in 33,000 population or 1 in 100,000, somewhere between that. So again, that's a fairly broad range, but you're going to see it. And I think the kind of received wisdom is that a GP would see one case of Cauda Equina in their career, and I think that's not true at all. I think I'd agree with what you said. If I, as you know, I work very closely with Sue Greenhouse and Laura Finucane, and we talk around this a lot in terms of how many patients we see, and or how many patients we're asked about in a week. It's got to be 10 to 15 patients a week who are presenting with spinal problems and possible Cauda Equina signs and symptoms. Not all of them have Cauda Equina, obviously. And I've been involved in discussions with Rob Tyre and Andy Bennett, Andy Cuff, and a few others, excuse me, around, do we know how many of these patients we see? And at the moment, we're trying to put together some data to actually understand what we see in physiotherapy and what we see in those first contact and advanced practitioner roles, because I don't think we really know the number of patients that we see.
Yeah, because I mean the frequency is certainly relevant, especially considering the seriousness of, even if it was incredibly rare, the seriousness is super high. And I recall on this podcast we had Alan Taylor describing cervicoarterial dysfunction and other issues surrounding hemodynamics, and obviously even when they're rare, when the seriousness of consequence is so high, then of course we should be sharp on it. But from what we're gathering and most information we know is that there's both a seriousness and a higher frequency than people often used to think, at least. And so for both reasons, really, we need to make sure we sharpen our game further. Now, when it comes to any current guidance on these sorts of things, with what are the key things that we're looking out for when we are assessing, and especially, like you said before, in terms of questioning to start with, subjectively?
So, obviously, we're interested in people's pain. We want to know where their pain is. So, the pain with Cauda Equina could be just back pain, or it could be back and leg pain. That leg pain could be unilateral or bilateral. But what's really important for us to know and to ask the patient is which direction is that pain going? Are things getting better or worse? Do we have someone who's progressing from back pain to unilateral leg pain to bilateral leg pain? So you've got an evolving, deteriorating picture. So that's really important to know. Are they presenting with unilateral back pain, unilateral leg pain to you, but last week they just had back pain? So we just want to know which direction things are going. So that, in terms of your body chart, if you like, and your, how your symptoms are evolving, is really important from a pain perspective. We also then want to know about any changes in urinary function, and that could be frequency, it could be some hesitancy, it could be slow stream, it could be difficulty finishing, it could be unaware of passing urine, all of those. And there's a whole host of confounding reasons for those symptoms, but we need to ask. And similarly with bowel, exactly the same questions. Can they go? Do they know they need to go? Has their bowel habit changed at all? Are they aware that they've stopped? And then obviously sensation-wise, can they feel when they're wiping themselves after going to the toilet? And from a sexual function point of view, can they, for men, can they gain an erection and keep it? And is ejaculation normal? And then for women, is vaginal sensation normal during intercourse? So they're fairly blunt questions, are fairly clear questions. Not everybody with those signs and symptoms is going to have Cauda Equina. The vast majority won't have. We know that. We know that from the evidence that something like 16% of patients with Cauda Equina symptoms actually have Cauda Equina compression. So it's a small hit rate.
So quite a number of questions there, which we're asking, and what I'm kind of interested in is, do you feel that there's priority questions there and then follow-up questions if someone's answering to the affirmative, or are they more of a sort of a blanket set of questions in which there's not necessarily a hierarchy to their accuracy?
I don't think there's a hierarchy in terms of asking them, but I think all of these are. It's like University Challenge. These are your starters for 10.
Right, okay.
These are not.
Sure.
The whole point. You don't get all your points for asking these questions, because all they are is indicators to ask more questions. So that it's never the first question that you're going to get all the information from.
Okay.
And I think this is where some of the bilateral sciatica issue came up, which we might talk about later. But certainly. I think it's a starter for 10. Right. So if someone has bilateral sciatica, we need to ask lots more questions. If somebody has some change in their urinary function, we need to ask more questions, because it could be that they've got stress incontinence. It could be they've got a UTI. It could be they've got a kidney infection. There's a whole host of things that would unpack that for us.
Yeah. Okay. And so on the question hierarchy, let's say, I'll admit that asking after bladder and bowel function, and particularly say loss of bowel function and urine retention, that sort of thing, it just tends to be a matter of I can't think who I wouldn't ask those questions really with regards to presenting with back problems, particularly ridiculous ones. But as a general rule, it's actually only when really needing to zoom in when some of those more standard questions have been asked that I might ask as to whether ejaculation is normal in a male patient, for example. And I'm inviting you to tell me that that's a mistake of mine, if so. But I'm just admitting that there are probably lower hanging fruit questions, if I call it that.
Yeah. Well, I think you're right in terms of probably normal practices. People tend not to answer sexual function questions, so I think people are fairly comfortable and aware that they should be asking bladder and bowel function and saddle sensation. But even as I've said earlier, some of the national guidelines don't mention sexual function. However, sexual function is equally as important, so it should be asked.
I tend to ask about on reflection. As standard, I'll ask about any changes to your genital function. Am I being too broad, do you think?
Yeah. Yeah. Well, what does that mean? The patient needs to be very clear about what you're asking, and what you're asking is, can they get an erection? So genital function, you know what that means to you, but that might mean something very different to the patient.
Yeah.
And I think this is where, from a legal perspective, a lot of the problems arise is the patients don't understand what they've been asked. Sue Greenhouse's work, where she interviewed, I think it was 29 patients in her qualitative study. And all of the patients remember being asked about their bladder and bowel function and about their sexual function. None of them knew what the relevance of those questions was. When they were asked about their sexual function, they all thought they were being asked, were they sexually active? So, that's the fault of the physio.
Yeah.
Or the person asking them, because it's not being made clear about why those questions are being asked. If you come back to your question about sexual function, there are, at least 3 legal cases that I'm aware of that sexual function wasn't asked and was the only thing that wasn't asked by these were GPs, and they were found to be negligent for not asking it in cases of Cauda Equina.
Right. Yeah.
So okay. I think I would, and we would recommend that you ask sexual function and give it the same priority as the other questions, because it might be the only presenting feature.
Yeah, and so do you think for that to be occurring, and for me to fall into that trap to some extent as well, do you feel that is because they are, I'm going to say, less famous or notorious questions to ask, or is it that we are struggling with a taboo and being a bit, for want of a better term, sort of shying away from sexual function questions because we feel awkward?
It's probably a bit of both.
Right.
Probably a bit of both. And I think, increasingly, we need to be working. I suppose, what am I trying to say? Increasingly, I've been working with women's health colleagues and men's health colleagues about what they do and what we do and how that crosses over. And it's interesting. They're very, very comfortable with these questions, and they're very clear with the questioning. So I think we have a lot to learn from the pelvic and obstetric gynae physio group, the POGP group, from their encounters and how they ask questions. Because they're not worried about it. They don't have any concerns about asking those questions. They're very clear about that. So I think there's something around the kind of professional history of what we've been used to as MSK physios. But I think we just have to, get on with it, really.
Yeah, well, exactly. When the consequences are so high, then certainly us trying to get over certain minor blushes is the least of his worries, isn't it? Really. So I'm with you.
I think so. No, there are challenges. We live in a multicultural society, and actually, there are some cultural issues about asking some of these questions. Yeah. So again, that might be that can be a challenge. And I think some of the the credit cards, the printed cards in different languages have been very useful in helping people to bridge that gap.
Sure.
And we had an example came back this week. People keep on kind of sending us stuff. It's a Polish chap who had been back to Poland. This was, I think, somewhere up in Cambridgeshire. Being back to Poland with his back and leg symptoms. He'd been asked questions about bladder and bowel. Hadn't really had any symptoms. Then came back, was asked by his GP again. Hadn't really kind of thought they were important. Physio gave him his Polish translation of the card, and the guy started crying. And he's weeping because he's reading everything about his sexual function and saddle sensation, and in kind of plain Polish, if you like.
Yeah.
It was all very, very much in your face. So I think there is something around that.
Right.
Definitely about the communication.
Yeah, for sure, and the multiple different ways of us trying to reach different audiences, but also making sure we're as clear as possible, however we do it. Just onto the location of symptoms then, with regards to you'd suggested then that if someone had leg symptoms, particularly bilateral leg symptoms, then you would making sure that you zoomed in closer and tighter to some of the Cauda Equina screening.
Yeah.
Is that I can understand the logic both in terms of anatomy, physiology, and my experience, but I just wonder, does that play out in terms of the data for majority, say, of Cauda Equina cases to, if they have pain, for it to be plus leg symptoms? Because I know it can exist with just axial pain, but does that play in the data?
The majority have leg pain,
right.
But I'm not aware of data that says how many have bilateral, how many have unilateral.
Sure. Okay.
What I'll be looking out for was progression from unilateral to bilateral, or progressively severe unilateral symptoms. Yeah. Plus or minus the neuro.
Yeah. And so if you're starting to, although they don't have any red flag symptoms, let's say they've got unilateral pain, and with regards to a more typical neuro screen, so not necessarily checking anal tone or doing anything with regards to what would be considered a more intimate examination, say that it's a myotome, dermatome, reflexes, Babinski, clonus, that sort of thing. Is the presence of, say, what are considered harder neurosigns then highly correlated with or raise your index of suspicion?
Yeah, it should do. And I think, and again, this is an area that's again a little bit grey in terms of, what are your red lines and when are you going to refer on? Yeah. So, particularly with neural integrity testing, the myotomal testing is key. And if you have 2 levels that are grade 3 or below, then that should be a trigger to investigate.
Sure.
And I think that's again, it's not a hard and fast rule. Some people will say more than 2, some will say 2, and what would you do if you had 2 levels that were grade 4? What would you do if you had 1 level that was grade 4 and 1 that was grade 3? Yeah. Or 1 that was 4 and 1 that was grade 2, which are all relatively common scenarios. Well, in that case, you've got a clinical decision to make.
Yeah, exactly, and
and you've got to manage that risk.
Yeah.
So I think a lot of what we have to get used to in either first contact roles or advanced roles or in a normal physio role is you've got to manage risk.
Of course.
So that as a profession, we're probably a little bit less mature at that than the medics.
Right. Yeah.
I think we're gradually realising that we do have to manage risk better and understand how that we are in a risk management game.
Yeah, well, it's the again. I think we're kind of we're kind of maturing in realising that there's no overt threshold. Just as we're coming to realise that algorithms aren't going to play out in the diagnostic categories that we always some hoped would just emerge, and best practice would come from guidelines that meant that we didn't have to lean on the grey areas as much, but that's just not happening. If anything, it's becoming more grey. But in instances like that, there obviously has to be thresholds that aren't necessarily just based purely on personal hunch. But I want to just touch on potential false positives and negatives then in this instance. So what I'm mindful of is that, say, when people answer your bladder, bowel, and sexual function questioning, even when thorough, to the negative,
Yep.
how protective is that to us when, say, that they might have a back and leg pain presentation, and how frequently do they then have a story in Cauda Equina cases where that was the original presentation and it took a turn for the worse?
That was the original presentation in the first negligence case I was involved in.
Sure.
It was a lady with severe back and leg pain in an S1 distribution. So it was something that you'd see on a daily basis.
Yeah.
So I think we can do what we can do. If you've asked your screening Cauda Equina questions, your bladder and bowel function, saddle sensation, sexual function, those are all normal, but you have someone with back pain and leg pain that's stable, then would you scan them on the same day? No. Would you scan them at all? Probably not if they haven't had treatment. Would that be a reasonable thing to do? Yeah, it would. That would be a reasonable way to manage that patient. However, if you had the same patient who had, again, no Cauda Equina signs, or symptoms, no Cauda Equina symptoms, but had rapidly deteriorating back and increasingly severe leg pain, that would be a different picture. So you might manage them differently. Those patients you might well scan and will be justified in doing so. Okay. But you wouldn't be necessarily scanning them with a query of Cauda Equina compression. You'll be scanning them with a query of severe radiculopathy.
Yeah, query compressive nerve lesion, which obviously comes to this then, and with regards to the neuroscience that might be found objectively then. So let's make a case, and I'm going to force us into the grey area of saying that there's not necessarily a massively overt weakness, but you've got a clear difference in resisted dorsiflexion, for example, from one side to the other, or even from what you would expect someone of that age, wellness, fitness, to be able to return in terms of power. Say that is occurring. How reassured should we be by, say, them moving in the right direction with treatment, or even with natural history? It's just as time is passing, they're doing well. Is that something that lures us into a false sense of security, or is that actually?
I don't think it's that really. I think that's just a reasonable thing. It's a reasonable way to manage them. If people are improving, if they have mild neurological deficit, if it's going in the right direction, then in terms of sensible management for those patients, well, conservative management would be a sensible way to manage them. If they're improving in their function, their pain levels are improving, they have mild neurological deficit, well, you're certainly not going to scan that person on the same day, and there may not be any mileage in scanning them at all, because the chances are they're going in the right direction. They'll improve with sensible conservative management. So from a kind of patient management point of view, it makes sense, but also from a legal point of view, the question is that a reasonable way to manage this patient? Well, yeah, it is. Would a reasonable body of people in the same position with the same skills do the same thing? Yeah, they probably would. And I think that would be a reasonable thing to do.
Right. Okay. And so, can you describe to me what safety netting is as a term, and therefore how does that help us to manage that risk beyond the clinic room?
Yeah, safety netting is really just about involving the patient in your clinical reasoning and explaining to them the consequences of any new symptoms that they may develop. So this is really about getting the patient on board with understanding their condition and understanding the potential serious consequences if things start to go wrong. So they need to know what to look out for. So this is just about saying that if this happens, if you start to develop any bladder or bowel signs or symptoms, such as ... if you start to lose sensation or have altered sensation around your genitals or your back passage, or if you start to not be able to get an erection or ejaculate, or you lose sensation in your vagina, you need to go to A&E. So we need to, in the safety netting, we need to describe what the patient needs to look out for, and then we need to tell them what to do. and in what time frame. So it's absolutely clear. So you can either document that in your notes and say, I've told the patient if they develop X, Y, and Z, then they need to go to A&E immediately. So then you've covered all those three bases. And from a patient perspective, they understand. If you've got some written information that you can give the patient, all the better.
Yeah, and doing that as a matter of routine for all back pain patients.
We don't recommend. So myself, Sue, and Laura, this is one of the big questions we often get asked: is should we be safety netting every single back pain patient? We don't.
Right.
We don't recommend it.
Okay.
Just because we don't think every single patient's at risk. So we're looking at those patients who are more at risk. We would safety net people with any leg symptoms.
Yep.
Or people with worsening symptoms. Okay. So that would be, it's not such a big net, if you like. It's a slightly smaller net. It's still a big net, but it's not every single patient with back pain.
No, that's really helpful. Really helpful to understand for sure. And with regards to, although you're explaining to the patient what to do and how to act, where to go, is there another level to that where you then suggest or make any hints to what they should do when they get there and what they should say and what they should explain? Because obviously there's significant variation to how A&E departments behave in presentation of these patients.
Yeah, and it's a big issue because I think as physios we're probably ahead of the curve in terms of identifying these patients, and often we know this from some work that we've been doing. We know that people turn up at A&E and they get sent away. So 50% of them will be seen and scanned, and 50% of them will be sent away, and they'll turn up with exactly the same signs and symptoms. So it's a bit of a lottery as to who they see, what time of day it is, and all those sorts of things. So that's where we think the written information is useful. So the patients can take along, if you've given them some written information, whether it's the Cauda Equina cards that Sue's produced and that are on the MACP and the Dynamic Health website, or something else that you've produced, some written information that says, my physio's given me this. They've told me to turn up here if I've got one of these things, and I've got this, and this. They've said I need a scan. So that kind of written information has been useful for a lot of patients in helping them to access the system.
Right.
So they use it almost as a bit of a passport to get them through the system.
Yeah. And so on presentation to A&E, or in some services with certain pathways, they might go to a spinal orthopedic service in some circumstances. But in doing so and presenting to a medic in an emergency situation based on the signs and symptoms as we're describing them, how accurate and useful are some of the more invasive, for want of a better term, or the intimate examination, as I mentioned before, such as a PR, or to check the sensation in the genitals? Yeah,
they're not. That's the short answer. They're really poor tests. So none of the tests are particularly predictive of Cauda Equina. We know from a couple of studies. There was a study in 2017 looked at the physical tests and found that the perianal and perineal sensation testing was the best of a bad bunch, really. So this is a Koenig et al. In 2017. So they'd done a retrospective looking over 10 years from 2001 to 2010, I think it was. They found that the perianal sensation and perineal sensation was strongly associated with poor outcomes, and anal tone testing less so. So that kind of looked at the outcomes. But we know from other studies that things like anal tone testing are really poor. So Ben Gooding did a study in 2015, I think. He looked at around 60 patients, and the positive anal tone testing didn't correlate at all with positive MRI scans or Cauda Equina.
Right.
So, predictive value for anal tone testing was very poor. And there's a study by Corse et al. 2017, again, said very similar things, that the ability of clinicians to identify decreased anal tone, whether they're experienced or inexperienced, was very poor. And Michelle Angus up at Salford, she'd done really nice work looking at people with Cauda Equina, and her study showed that the test with the lowest predictive value for Cauda Equina was anal tone testing.
Right. Okay.
So half of the group that she looked at, I think she looked at around 320 people, about half the group who didn't have Cauda Equina compression had reduced anal tone.
Right. Okay. And so, what's your position on that being something that is a test that should be upskilled by spinal APPs and other first contact professionals?
At the moment, in terms of the evidence around the tests, you'd have a good case to argue that you shouldn't be doing the test. However, the test is in every single guideline that you'd look at.
Yeah. Okay.
So from a legal perspective, you'd have to be pretty brave not to do it, and you could stand up in court and justify it in terms of the evidence, but you'd have to be pretty brave to do that. And I think from a patient management point of view, if you ring up A&E, you're a physio, you ring up A&E, and you've got a patient with with suspected Cauda Equina syndrome, they're going to ask you, what's the bladder function like, what's the bowel function like, what's the saddle sensation like, and what's the anal tone like? And if you haven't tested it, then it's going to make it potentially more difficult for you to get that patient seen and managed. So we currently recommend it. We do it. All of our advanced practitioners do it. All of our Band 7 physios do it in the physio department.
Yeah. So
we get trained by our women's health team.
Yeah.
And it's not the most unpleasant thing. It's not the most pleasant thing. It's just a thing.
Yeah.
It's just something that helps to get the patient on their journey. However, for everybody involved, it would be better if we didn't have to do it, I think. Sure. And I think there'll come a day fairly soon in the next couple of years, probably, where anal tone testing will fall off the guidelines. Okay. This was part of the discussion we had at the National Back Pain Pathway Clinical Network, and that involves physios and surgeons and neurosurgeons, and a lot of the surgeons were actually we don't do it, and we don't see why we should do it, because it's invasive, it's unpleasant for the patient, and it has very poor predictive value. So which is what the evidence says. So I suspect that's the direction we'll be moving.
Okay.
For saddle sensation test. Sorry.
Yeah, that was exactly what I was just going to ask. Okay. Is to go to saddle sensation.
So saddle sensation testing, I think there's, the evidence isn't brilliant, but it says yes, it has a better predictive value. So we'd certainly recommend that everybody does that, and that's to include light touch and pinprick sensation. So obviously, you need to be trained, you need to be competent, and ideally you need to be chaperoned.
Yeah.
Or at least offer the chaperone, and get the chaperone to sign your notes as well. It's a personal thing to do to somebody, but if you've explained why you're doing the examination, what the importance is, then I think actually, I've never had anyone refuse, just because you explain this is. I'm concerned that this is a serious condition, and this is one of the tests I need to do that will help me make a decision. Mm-hmm. So as long as you explain it well enough to the patient, I think most are accepting of it. If they're not accepting of it, that's fine too, but you just need to document that. So you need to make a note that you've offered, you've suggested, you've explained the consequences, and the patient still refused. Well, that's fine. And if they do refuse and you still have a suspicion of Cauda Equina, the patient still needs to be scanned.
Of course.
So it doesn't kind of change that decision.
Yeah. Okay. And so, although we've talked about those specific objective tests now, in most circumstances, most therapists listening wouldn't be trained in that direction. So, can we try and do a bit of a talk about certain thresholds for referral and that risk management circumstance, where we can then think what feels like it's a let's say classic cases in which it would meet or wouldn't meet a threshold, both for you personally and also having taught this to many Joe Blogs physios like myself.
Excuse me. I think if you think about the a useful starting point would be the categories of Cauda Equina syndrome that were described by Todd and Dixon, so that broke it up into Cauda Equina suspected, Cauda Equina incomplete, Cauda Equina retention, and Cauda Equina complete. So those 4 categories really kind of outline some of the presenting clinical features that should kind of steer us a little bit towards how we manage these patients and what questions we ask. So the Cauda Equina suspected is those patients with severe back pain, severe bilateral leg pain, or progressing unilateral leg pain. So in those patients, we're going to be asking more questions, delving a bit deeper in terms of pain behaviour. Might steer us towards doing some of our neurological tests, some neurodynamic tests. For the incomplete Cauda Equina, those are patients with difficulties either in initiating urination, loss of desire to void, poor urinary stream, needing to strain to micturate. Again, we'd need to ask more questions. If that was a 55-year-old man who was also getting up in the night and had known prostate disease, then he might be less worried. But in the absence of any other kind of confounding diagnoses, then those 2 categories are the 2 categories where we can make a difference to the outcome. So generally, once people get into retention, or so in urinary retention with overflowing continence, or in complete Cauda Equina syndrome where they've lost perineal sensation and anal tone, those patients have their chance of good outcome is virtually nil from surgery, even if the surgery is done soon. So we need to try and get those patients in the suspected and the incomplete categories.
And so when there's a pattern of symptoms that make you feel that you want to send someone to A&E, either at that moment or they then develop those symptoms, having you safety netted or given them some literature, what do you feel is the right, what do you give as guidelines or guidance to therapists with regards to what to send them with? Is that a written specific letter? And obviously that's the thing that will vary as to whether or not they've got the symptoms as they're describing that with you, or whether they emerge after the appointment. But let's say it's one that they've presented with a problem that you then suspect it, and you're sending them there and then.
Yeah, if we suspect it, we'd recommend that people send some written information. So a lot of places do pro formas, so they'll have a pro forma that will cover the presenting signs and symptoms of Cauda Equina, and they'll have time and date, and any examination that you've done on there, which is a nice way to do it. It makes it quick and easy. Or you can do a standard letter, dear A&E, and send them down. If you're sending to A&E, we'd recommend that you phone ahead, know your local pathway. Our pathway is that we contact the orthopaedic registrar on call, and they will then meet the patient in A&E. But they'll have a phone call, and then the letter will go to the person we've spoken to on the phone. And a lot of places will do it in a similar way. But certainly something written is useful. Otherwise, the patient just turns up at A&E and says, "I've been told to come here," and that can be a bit of a challenge. So you need to get a name of who you spoke to, the name of the person who the patient needs to ask for. I've been told to ask for Dr. Jones. He's spoken to Chris Mercer at 3:20 this afternoon, and I was told to come here. Okay.
And I've worked under pathways such as the one you're describing there, and part of the reason that they emerge is that you're inviting a highly specialised person to go and assess them in A&E, in part because there is such variation, which we touched on before. What do you feel are the steps that we as a profession and the wider MSK industry need to take in order to improve the consistency and to make sure that these fewer people turned away unjustly?
That's a really big question.
Sorry, I knew I'd have I usually have one good one a podcast, Chris.
Well, it's the right question, and I think the lack of consistency is the challenge, and I think that's what a lot of physios, first contact practitioners, etc., find so frustrating, because they have patients in front of them who are, presenting with all the signs and symptoms of this extremely serious pathology that requires urgent investigation. The next they hear the patient's ringing them from home saying, I've been sent home. What do I do now? So you get the patients bouncing around. So then, you bat them to A&E and they bat them back to you. So then in terms of your duty of care, the duty of care comes back to you. And what do you do with that patient then? So I think the only way we can move forward is through education, really. And I think we need to change the guidelines. The guidelines have, and the traditional teaching is still very much around looking for incontinence and looking for retention in terms of bladder and bowel function. And actually that's too late. So these, Todd described these as white flags rather than red flags. This is a kind of, we've given up then. You've surrendered this patient to Cauda Equina by this stage. But there's still, I think, a wide misunderstanding that those are the signs and symptoms that we should be concerned about, not the earlier signs and symptoms. So the patients that we send with the early signs and symptoms get turned away. The patients that turn up who are incontinent and in retention get seen and scanned urgently. So I think there's a lot of education work to be done and some joint working with colleagues across the board, really. And I think it'll come in time.
Yeah,
it's a slow thing.
One of the things that will naturally drag it that way, I suppose, is the medical legal circumstance, which I do want to unpack in a bit more detail with you. But before we go there, because I know we're going to be there for a little while, I imagine we'll need to. I just want to make sure that I hone in on some of the real challenges that people often face with regards to the masquerading situation around bladder as well as sexual function and bowel function, but particularly say people with intermittent incontinence and things like that can then have symptoms that would be, if they were presented in an otherwise well person that this was new for, it would be more obvious. However, with people with various different bladder, bowel and sexual function issues as standard, then that doesn't necessarily mean they're any less likely to also develop a Cauda Equina. And so I just wondered if you have any go-to things or examples that you can bring to bear on that issue.
Again, I think it's really difficult because I think a lot of the vast majority of the cases that we see who have suspected Cauda Equina aren't the patients that are really obvious. Anyone can spot the obvious ones. Right. That doesn't need training, really. You just need to tick a box. So most of the patients either have these, they can be episodic bouts of incontinence, as you say. So let's say somebody turns up, they've got back and leg symptoms that are improving, and two months ago they had an episode of incontinence when the back pain started. Are you going to send that patient to A&E on that day? Well, no, probably not. And would that be a reasonable thing to do? Probably. No, but there's a couple of probablys in there. And would I be comfortable taking that risk and managing that? Yeah, well, I would, and I think that would be a reasonable decision because the patient's improving generally. They had, one episode of incontinence. We know that pain can affect, continence. We know that a lot of the non-steroidals can affect continence. We know that the things like gabapentin can affect, continence. So those things, if it's 2 months ago and it hasn't happened again, I'd be okay. I'd manage that risk okay, and I'll sleep reasonably well. If the patient 2 months ago started with their back pain and then their back pain turned into leg pain and then it was unilateral and now it's bilateral, and they've had 3 episodes of incontinence along the way, I'd sleep less well if I didn't send that patient for a scan.
Sure.
Would I need to send them on the day? Again, that's going to be a challenge.
It's tricky, isn't it? But I hear nothing that I disagree with, but I just feel like it's a bit of a poor state of the system where inevitably Chris Mercer is likely to tolerate and be able to manage more probablys than Jack Chew is, and Jack Chew is going to be more likely to be able to tolerate more probablys and manage that risk compared to a new graduate. Now, although that is similar in various different circumstances, and that's the nature of reasoning and experience, etc., and expertise, I also just feel that when it's something as serious and as important as this, that that is a significant grey area that between clinicians mean the lottery that patient is having, depending on who they see for how they get managed, is far too broad for a condition like this one, surely, as it currently stands.
It is broad, but it reflects the reality, and I think that's I talked a bit earlier about that kind of risk management, and we have to accept that we're doing some of that. I mean, I think what is really important is making sure that you have some governance pathways, that you have someone to ask. I still ask people. I ask lots of people. If I'm not sure, I'll go and ask, a medical colleague, or I'll pick up the phone to Laura or Sue and say, look, what do you reckon? I'm not sure about this one. Sure. And that happens all the time. And I think you would hope that from more junior members of staff there would be a ladder that they could get some advice from, and work their way up that ladder to get some sensible advice. And that would be my expectation of a less experienced member of staff, is that they don't necessarily fire everybody off to A&E. That wouldn't be appropriate. But they do ask the questions of their senior and say, look, I'm not sure about this. What do you reckon? That's their duty of care to the patient, is to work with their level of experience and then ask the appropriate questions. And if they do that, then I'm more than happy with that.
One of the things that I think all naturally bridges into the medical legal discussion is one of how feasible and how well set up are we, particularly speaking in our context in the UK, for a 24 an MRI that is truly urgent, and we're describing a process in which I can understand the reasoning as well as the pragmatic application as we've described in this chat, but then we're pulling a trigger and it's like there's no such thing as too soon for this patient. What is on the ground, it's not necessarily likely that they're going to have that
it's more than likely that they won't. It's more than likely they won't, unless they're referred to a spinal centre that has 24-hour scanning. The chances of them getting a scan are very small. There was a study published about a month ago, the Entice study. I don't know if you've come across that. This was a study looked at about 4,500 referrals for suspected Cauda Equina. The vast majority, I think about 70% of them, were referred at night, so didn't get scans. How many of them? Yes, 4,500 referrals, and about 70% of them didn't have scans because they couldn't get them. They were referred.
As in within 24 hours, or they didn't have a scan full stop.
Didn't have a scan on referral to the specialist unit.
Right. Yeah.
So they were referred on their subjective history, but because of the lack of access to 24-hour scanning, 70% of these patients turned up without their scans.
And how much do you? I know it's going to be hard because I'm asking you to have more of a punt than the data will help guide us on. But how much do you think of that is purely a provision issue, and how much is it part of the complacency or the system failings that we've described before?
I don't think people are complacent. I think if we had more access to imaging for these patients, then I think they'll be managed better. We would expect probably about 16% of these patients to have positive scans. Which is a very 84% of these patients are not going to have Cauda Equina compression. Which is you could argue that's not a very good hit rate, but 1 in 7, let's say 1 in 7 patients that you send is going to have Cauda Equina. Well, I think that's a reasonable hit rate. We know if people arrive with a scan, if they've had a scan done, they're more likely to go ahead and go on and have surgery, which kind of makes sense. I think something like 8% of those patients in the Entice study who didn't have a scan ended up having surgery. So what we're looking for is signs and symptoms with concordant imaging to tell us they've got Cauda Equina compression. Right. They've got Cauda Equina syndrome. So the syndrome is the symptoms plus the imaging. We need both.
Yeah.
But I think it is a difficult issue for us in terms of imaging, just because the system isn't there to and isn't able to cope with the demand.
And in that circumstance, the question that is it's painful for many thoughtful, and most are, therapists to know that essentially they have done the right thing on their end and they're sending someone on. But it's also incredibly disheartening that it's not as if they then inherently sleep easy on the fact that their conscience is clear if they know that there's been a mismanagement or a circumstance where that patient is going to have life-changing effects. So, but the question does remain for people as to how culpable and how liable, in a literal sense, they are for having done the right things, and then the system isn't equipped, or another of their medical colleagues don't.
They're not liable. Your responsibility, or our responsibility, is to get the patient, to someone, either to a scan if you're able to scan somebody. If you have, if your job role enables you to scan somebody, then your role is to get them scanned on the day. Mm-hmm. If your job role doesn't enable you to do that, then your responsibility is to get the patient in front of somebody who can make that decision about it. Mm-hmm. And that's, if you fulfil that, then you fulfil your duty of care to the patient. Yeah. You haven't, for a negligence, you need to have a duty of care for the patient. Well, that's a given. You also have to breach a duty of care, and that breach needs to lead to harm to the patient. Well, if you've seen the patient, you've referred them to A&E on the day, and they got to A&E and A&E have sent them away. Well, you've done your bit. You've got them to A&E. You've put them in front of someone to make a decision about whether they should be scanned on the day. And that, as you say, that's not going to make you sleep any easier if the patient ends up having Cauda Equina, having been sent away. But that is, in most roles, that's the limit of what you can do.
Sure. No, I understand that. And so then, it's one of those questions where I hope I know the answer, but you never know. What is the legal implications of clearly missing red flags when essentially they've presented to you?
If somebody presents with clear bladder and bowel signs and symptoms with their back pain, and you don't give them the advice to get in front of someone or get into a scanner on the day, then you've breached your duty of care to the patient. Mm-hmm. So from a negligence point of view, there's a breach. So that you've breached your duty of care, and chances are that patient will then come to some harm. So as a result of your breach, they will they'll have a poor outcome. So you will be found clinically negligent. And
you will be then, just to walk that a little further, would that then, what's the likelihood of then losing your license, and then is there chances of even criminal charges being made against you?
I don't think from it there'll be chance of criminal charges, but there'll be charges in terms of legal cases against you potentially, absolutely, and possibly rightly. Mm-hmm. From a patient who's left with these devastating consequences, well, it's not unreasonable for them to seek redress if you've not performed as you should have. Mm-hmm. The chances of you being struck off, I think, are probably pretty slim, unless it's absolutely barred or obvious and you've done it a couple of times. The chances are that you'll be maybe have some degree of supervised practice. Okay. And requirements for you to be retrained or to demonstrate that you've improved your knowledge.
Mm-hmm. Okay. And so one of the reasons for me wanting to just lay that out as clearly as we can is to try to frame it appropriately for why this might be something that people are tempted to apply defensive medicine for and be more trigger happy on referring. As a matter of, on the balance of risks as we've described it, how many probablys, as I described it earlier, people are willing to sit with. We can make sense of why people would err on the side of referring. for various reasons, including self-preservation ones.
Yeah, I mean, what you should have, and what everybody should have, whatever environment you're working in, is a clear pathway. There should be a clear protocol of what you do with patients who present with possible Cauda Equina Syndrome. If you have a pathway that's written, that's your guiding document. Now, that might be slightly different, depending on your job role or your circumstances or your locality, what's available to you. If you have 24-hour scanning in your trust, then obviously that will be part of the pathway. But if you have a pathway that's clearly written, clearly documented from a legal perspective, what they want to know is what's your pathway for these patients? What's your normal protocol? What do you do with these patients? What's your criteria for urgent scanning? What tests do you do for Cauda Equina? What questions do you ask? So if that's all documented, you have a clear documented pathway, that's then your fallback. That's your fallback for all your clinicians. So for whether you're a new grad or whether you're a consultant, that's the pathway you should follow. So there's some consistency across the where you're working.
I want to come back to that perhaps in case I forget. So do remind me to come back to it, just with regards to how much that governance, the process that you're describing, supports each clinician and each system with differences in emerging opinion. So I might come back to that if I forget then. But I want to ask as to what it is about Cauda Equina that's particularly why it's become such a hot topic more recently, and why it's why those differences of opinions are emerging. Do you have a sort of take on that as a broader point?
Yeah, I think it's been driven by litigation. I think that we know that the CSP has been concerned about its litigation profile as a result of some Cauda Equina cases. We know from Connect's point of view that they had a few cases, or at least one case that didn't go as well as they'd hoped. And I think across the country, people are having more and more cases. As we're more exposed to these patients, then that's the likely outcome. And it only takes one legal case. The average payout is something like £660,000 now, whereas 4 or 5 years ago it was around 230,000.
Right.
So it only takes one or two of those cases for your trust or your employer's insurance premiums to be significantly affected. So I think there is, as ever, money is a bit of a driver. So I think that's driven. It certainly drove, from the CSP's point of view. They asked Sue and Laura and myself to do the YouTube video and some stuff on the website just to raise kind of awareness. So they're concerned about their insurance premiums.
So Nick Todd's name's come up a couple of times in this chat, and he's done a lot of work on this. And one of the things with him is that there's his emerging opinion is that essentially, because of the inaccuracies that we've described before and the lack of sensitivity to specific both questions and tests, means that a large central disc prolapse is a key indicator for that 16% of those are going to go on to develop Cauda Equina syndrome, and therefore in his instance he feels that then a classic indicator of something like that in an anatomical sense is bilateral sciatica, which is therefore a more relevant red flag than yesteryear might have thought. And so from that, there's a suggestion that obviously the same provision issues that we've described before are relevant, but in this instance he's suggesting that bilateral sciatica is an indication that there should be a pertinent scan. What was your position on that? Let's say with them, in absence of other red flag symptoms in terms of organ function.
Well, this is, I guess, kind of responding to Nick Todd's, to that question directly, but also to goes back to the white paper from Connect, and their stance was that people with bilateral radicular pain should have an urgent scan, should be scanned on the day. And I think the response that myself, Sue and Laura put together was really to try and put a bit more kind of clinical reasoning and a bit more nuanced approach to that. So yes, bilateral leg pain should be a start of a 10. It should be your opening gambit. You want to ask a bit more and you want to investigate a bit more. So people with bilateral leg symptoms in and of themselves, if they have normal neurology, normal neurodynamic tests, and no other Cauda Equina symptoms, then, or even if they had positive neurodynamic tests, would we suggest you scan them on the day? No, we wouldn't. Would we suggest you safety net these patients and say, if you develop any of these other symptoms, any other Cauda Equina symptoms, yes, we would definitely safety net them. If they had bilateral leg pain plus abnormal neurology and deteriorating neurology, then yes, we would suggest they need a scan. If they had bilateral leg pain and Cauda Equina symptoms, it's barn door and it's an emergency scan. So it's really just to try and nuance it a bit more. I think if we end up sending every patient with bilateral radiculopathy to A&E on the same day for imaging, the system's going to fall apart. It's not coping at the moment. So I think our hit rate for positive scans, positive Cauda Equina for people with just bilateral radiculopathy will be very low.
In the intro to this podcast, I'll try and bring people's attention to that exchange because it was brilliant. The white paper from Connect and then your response. I forget the colours, forgive me. But yourself, Sue, and Laura, and for me, that nuanced position that you then describe in that, and you're now describing here, is one that is well within my comfort zone. Obviously put much more succinctly than I could have done, but it was very reassuring. The bit that I'm intrigued with, though, is that nuanced perspective that then brings the reasoning to bear and the science to bear and the logic based on the pragmatics of what we've described in this podcast. It's only as strong as the judicial process will support a clinician in. And so what I think is the news is to many, including myself, is that if then there's a circumstance where bilateral and new radiculopathy was the only red flag in that circumstance, you then appropriately safety net someone. They then present and do lose organ function or sexual function, and then in a court of law, when that is then brought to bear, then the likes of Nick Todd are then in a situation where they feel that would have been sufficient for an urgent MR.
Yep.
I know many are concerned.
I understand that concern, and I think, I suppose my reassurance would be Nick Todd's obviously got lots of experience in this area, but has a particular slant. His slant's not agreed with by the whole of the spinal surgeon community or the neurosurgical community. So this was part of the discussion we had at the National Back Pain Pathway Clinical Network meeting. And we discussed around this, around bilateral leg pain, and we discussed around the response that we're given to the Connect paper. And the general feeling and the recommendation from the National Back Pain Pathway was that we go with a more nuanced approach, and that will come out. That's due to come out in the next month or so, to come out from the National Back Pain Pathway, which we're hoping will then be agreed by UK Spine Society's board, and then we can use that to influence the NICE clinical knowledge summaries to discuss with them. Because the blogs and the kind of to's and fro's in the blogs did raise some interest from NICE as well, and they'd invited us to come back to them once we'd had the National Back Pain meeting. So I think there will be a clearer kind of defined statement on that, which hopefully will cover off some of that kind of concern that you've raised.
That's that's great news, and that's reassuring. I think for many, it certainly is for me. I think as a broad thing.
Can I just go back to the Connect thing? I thought it was a really positive kind of exchange. So I think, whilst we disagreed with, what their approach was. Actually, the exchanges we had was across Twitter and beyond were really positive, and I think in terms of raising awareness of Cauda Equina, it's done a really good job. So hats off to them for that.
Yeah, no, exactly, and I think for being able to observe that and to try and work it out, but it was just something that left a few lumps in people's throats, in part because I don't think there's many clinicians that are brave enough to. What it felt like was that you might end up with Nick Todd as an expert witness and Chris Mercer as an expert witness on either sides of a case, and then the clinician that ended up making what could be considered by some a mistake being, well, I could just have avoided even risking that mistake had I have just been more defensive and therefore more trigger happy, as I've described it, to refer. So they're thinking, sod it, I won't back the nuanced approach winning out in the end if I can avoid it just by being erring on the side of defensive medicine. So it's reassuring, as you say, that there's a consensus that seems to be moving in that direction.
I think from a legal point of view, it's almost reassuring that there are differences of opinion. There isn't just one opinion. There is and there are different approaches, but there's a significant body of people who would go one way and a body of people who go the other way.
Sure,
so we've got and that from a legal perspective is equally as reassuring. Because it's saying you're not out on a limb. If you were to take a nuanced approach, there's a huge body of people who would say that's a sensible way to manage it.
Yeah, and so Nick Todd's position on this is on the cautious side of medical opinion, rather than it being central to the consensus that our medical colleagues are at the moment.
I think so.
Yeah. Okay. And that's reassuring in itself. Do you see what I mean? I was worried that perhaps you had a medical fraternity with a position that was in keeping with Nick Todd's and say a physiotherapy community, which I consider myself part of in advanced practice as well, that would be very much in line with yours and Laura's and Sue's position. And they'd end up coming to blows.
The National Back Pain Group has some, hugely eminent spinal surgeons on it. Of various kind of shades of spinal surgeons, and they were similarly minded to us. So I think that's reassuring. Certainly reassuring from mine, Sue's, and Laura's point of view.
No, fantastic. No, and it will. Only good can come out of this if the conversation continues to flow in the direction it is, because we can come to understand and respect each point of view, and then try to come to a solution, but recognising that it needs to be primary care, it needs to be secondary care, it needs to be the sharp end A&E departments, the consistency of pathway. It also needs to be, of course, cross-professional. It's very important. So on that, then I want to ask as to what does the future hold for physios and Cauda Equina with regards to not just guidance, but also I know that there's certain potentially even events and things like that we're bringing to bear. We're also having you at the Big R's conference in October to try and make sure we get more into detail, or potentially also the conversation will have progressed even between now and then, of course, so picking that back up just to make sure we're thorough. But what else we got on the horizon, Chris?
Well, I think, as you say, the discussions around the blog, there was a huge amount of discussion, and out of that we've planned to run 2 study days, one in London and one in Manchester. I think the London one we're looking towards the end of this year, and we've got fantastic sign up from yourselves, from spinal surgeons, from Connect, from Nuffield, from MACP, who are going to kind of run the event. Great. From the National Back Pain Pathway Clinical Network. So we've got and from 2 patient experts as well. So we've got fantastic clinical engagement, patient engagement, and a lot of interest. So I think that will be a really nice way to move the discussion on, as you say, with the Big R's as well in October. I think in the next year or so, I think the guidelines will change, and we'll clarify a little bit more in terms of what we should be doing, certainly around bilateral leg pain. There aren't any nice guidelines per se on Cauda Equina at the moment, so I think that might be something we can push towards working with NICE to do. But I haven't kind of approached that yet, but I think that would be a sensible thing to try to do.
Yeah, no, fantastic, and as we're saying, it's just really reassuring that not only are these problems emerging, but there's solutions being discussed all the time, and
Yeah.
and respect for the nuance is coming to bear, especially. Unfortunately, interprofessionally, it sometimes does break down on those lines when you've got differences of not just opinion, but also a difference in legacy of who's responsible for what and where the book stops. And so, in this instance, it does sound like a really good fertile ground for healthy discussion, which is promising.
And the other thing that's coming on in the next probably year or so is the international clinical reasoning framework that myself, Sue, Laura, and James Self at Manchester are working on. So that's working with IFOMT and with the Physio First Private Practitioner Education Fund, who've helped to fund us, as have the MACP and CSP, to develop an international framework around 4 serious spinal pathologies, including Cauda Equina. So it's trying to get some international consensus.
Yeah.
So again, hopefully that will help to help people develop their pathways and help develop some consistency across the board.
Oh, fantastic.
So hopefully we'll get that done in the next year to 18 months.
Lovely. No, that's fantastic. So thank you so much for all that you do, Chris, and thanks for coming on the show today to explain not just the topic as a hot topic, but also we've taken a real deep dive into it from start to finish. Is there any way you'd like to point our listeners? How can they find out more from you and any courses you might want to plug or run?
Yeah, we run our spinal masqueraders courses through the MACP, so that's myself, Laura and Sue. Yeah, other courses are obviously available. Andy Cuff and Jack March do a great course, as does Steve Nawar, who are doing some great work around red flags. So, take your choice. There's lots of good stuff out there.
Yeah, and how do people find you? I know you're on Twitter.
Yeah, on Twitter at Merce Physio, or I'm happy to be contacted directly through my work email, which is christopher.mercer@wsht.nhs.uk.
Fantastic.
I might regret that one.
Maybe, you never know.
Maybe. I won't give my phone number.
I hope you don't get any overflow from our hate mail, because that's some nasty stuff.
Sure.
One of the things as well is that just to let the listeners know, and we mentioned just before we came on air that my dad had Cauda Equina and it's taken some persuading, but he's going to come on the podcast when we launch Patient Matters. He's rather reluctant. He's certainly not like his son in the attention-seeking front, so he really has taken some persuading. So,
if you can, Jay, it'd be brilliant. Sue's done some work with a lady called Emma Willis, who spoke at IFOMT, and I've been doing some work with a lady called Janine, who's a patient at work, a lady who had Cauda Equina, and it's extremely powerful stuff. So getting patients involved in this is the way forward. Absolutely,
and also I think we need to. You've just reminded me that we want to try and do that and involve that as soon as possible with patients for the conference as well. So thank you.
Great.
Thanks again.
Well, good luck with your dad.
Want to do that. Absolutely, yeah. Cheers, and
right.
Thanks a lot, Chris, and I'll speak to you soon.
Yeah, cheers, Jack.
Cheers, son. And that was session 65, wonderful episode. I'm sure you'll agree, but please do send us feedback on the various social media platforms as you find us on Twitter, Facebook, Instagram, YouTube, and beyond. We're also on Spotify if you haven't found that out already and you would prefer to listen to us there, but also available across all major podcast apps. But just a reflection finally on that episode. Absolutely wonderful to be reassured at the end there by Chris about the fact that some in the medical fraternity perhaps are being a little overcautious and perhaps overzealous in their calls for MRIs, particularly when it comes to bilateral leg pain in absence of other red flag factors. That is reassuring. It may well still go in that direction, and that is an ongoing discussion, of course, but for now that is helpful for us to understand that there is a weight of support across various different factions, not just in physiotherapy, but across other medical communities as well, for us to understand that would be a little hasty for us to overhaul policy. But as we know, because of the litigious nature of this topic and because it's a very important, serious medical matter, we need to make sure that we are keeping up to date with the debate on this, and we will keep you informed as it happens, including at the conference. As I mentioned at the top of the show, this session will be discussed in more detail there. Please do check out reform.physio/. conference, or buy tickets.at/reformingmsk, and check out social media for future competitions that are coming out in just in a few days' time, actually, regarding the program launch and how you can get your hands on some tickets while they still exist. We're expecting another spike, and according to how the early bird went down and things like that, we certainly don't think they're going to be hanging around for long. So Manchester, 18th and 19th of October, is going to be our biggest event yet, and we'd love for you to join us. So if you enjoy this conversation and others like it, where we take deep dive debates into these topics, then please do join us there and tune into future Physio Matters shows. But as per usual, we leave the show with your favourite bit, which is Chris Mercer with our cheesy sign out. Okay, we'll see you next time, and thanks for tuning in.
You've been listening to the Physio Matters podcast, discussing physio matters, because physio matters.